Good evening, everyone. Welcome back to day two of our clinical module series in oncology. I hope you found yesterday's session engaging and insightful. I'm Mohammad Adnan Sheikh, PharmD intern and a MedoDrix member. Today we are diving deep into more about antineoplastic agent and many more. Over to you, Dr. Nazir Ali sir.
Thank you, Mr. Adnan, welcoming you all to this second day. So, am I audible to all of you? Can anyone please confirm?
Yes, sir, you are audible.
Let me share my screen. Anybody? Is it visible?
Yes, sir. It's a black screen.
Okay.
Yes, sir.
So,
Now,
okay, can I start?
Yes, sir.
Okay. So yesterday we have discussed about the treatment modality. We have discussed about the local treatment approaches and about the systemic. And regarding the local, we have discussed about surgery and radiotherapy. And regarding systemic, we have yesterday itself I told you we have chemotherapy, we have targeted therapy and immunotherapy. So those things we'll be discussing today. So first of all, regarding the systemic anti-cancer therapy, as I told you, we have a chemotherapy, we have hormone therapy, we have immunotherapy and targeted therapy. So immunotherapy, targeted therapy, which will be under the same category only because all the immunotherapeutic agents are targeted only. Okay. So, chemotherapy, we will be using some of the chemical agents which are prepared laboratorically, which will be killing the cancer, which will be producing the cytotoxic effects. So all these hormonal therapy, all these immunotherapy, targeted therapy, all these drugs will be inhibiting the cell growth and the further progression of the cell cycle, which ultimately result in cell death. Okay. So what is chemotherapy? So chemotherapy destroys the cancer cell and prevent them from further multiplication. So that's why they are called cytotoxic, which kills the cell. So as the chemotherapeutic agents kills the cancer cell, they are called cytotoxic. So in that we can define at the level of curative therapy and palliative therapy. Curative therapy, which may include radiation, with or without radiation and surgery, it will eliminate the cancer and there is no chance of relapse and all. But in case of palliative therapy, the tumor will already be metastatized. But in order to extend the lifetime, but it doesn't provide the complete cure from the disease. So just for the supportive, we are giving the therapy that is a palliative therapy. So regarding the sensitivity, certain types of cancers are highly sensitive to chemotherapeutic agents. We can take in terms of lymphoma, which varies from Hodgkin's lymphoma, non-Hodgkin's lymphoma, Burkitt's lymphoma, various types of leukemia, acute lymphoblastic leukemia, chronic and myeloid leukemia, everything. Small cell lung cancers and testicular cancers are all highly sensitive to the chemotherapeutic agents, whereas the breast cancer, the colon, and non-small cell lung cancers are having the intermediate sensitivity to chemotherapeutic agents. But these head and neck cancer, prostate, gastric, pancreatic, and all, they are low sensitive to chemotherapeutic agents. That's why for these cancers, there will be a concomitant radiotherapy in order to increase the sensitivity of the cancer cell to the chemotherapeutic agent. There will be adjunctive radiotherapy, especially for head and neck cancers. Okay. So usually in chemotherapy, all the protocol consists of multiple drugs. So those drugs will act by a different mechanism, but as a result, it will produce a cytotoxic effect. Okay, so those different drug will exert its cytotoxic activity by different mechanism and at different stages of cell cycle. It can be at G1 phase, it can be during the S phase, or it can be at mitotic phase. Okay. So when combining the various classes of drug, we can decrease the chances of drug resistance. So what are all the modes of chemotherapy? Yesterday itself we have discussed. We have adjuvant and neoadjuvant chemotherapy. Neoadjuvant chemotherapy is given before performing surgery in order to shrink the tumor, whereas the adjuvant therapy is given after the surgery if any microscopic metastasis is there, if any residual disease is there. So in order to mop up, in order to clear the complete, in order to provide the complete cure, so we are giving adjuvant therapy. And what about the primary therapy? So in primary chemotherapy, it is a anti-cancer treatment in a highly sensitive tumor. As I told you, lymphoma, leukemia and all, we will be giving a primary tumor. So for that, the chemotherapy, there is a chances for the complete cure. And about the concurrent chemotherapy, so the patient will be taking the radiation. For example, if the patient is having head and neck cancer, they will most probably getting the cisplatin. Okay, so this cisplatin is a platinum formation complexes, but the head and neck cancer is the least sensitive to chemotherapeutic agent. In order to increase the sensitivity of a tumor cell to the antineoplastic agent, there will be a concomitant radiation simultaneous to the chemotherapy. Okay, so four modes of chemotherapy: adjuvant, neoadjuvant, primary chemotherapy, concurrent chemotherapy, which is simultaneous with the radiation. So coming to anti-neoplastic agents, so you all know anti-neoplastic agents are used in the treatment of cancer. Okay, so they can inhibit the growth either by disrupting the cell division or by destroying the actively growing cell, which is cytotoxic, or else it will inhibit the cell division. So further progression can be inhibited. So in that we have cytotoxic neoplastics and targeted neoplastics. Under the cytotoxic only we will have that chemotherapy, everything. Okay. So now coming to the cytotoxic agents. So all these agents kills the cancer cell. Okay. So we have alkylating agents, we have anti-metabolites, we have some plant alkaloids which are mitotic spindle poisons, and certain anti-tumor antibiotics, and some other miscellaneous drugs like L-asparaginase and all. Okay, so under the alkylating agents, we have nitrogen mustards, we have alkyl sulfonates, we have nitrosurias, we have platinum coordination complex, and we have methyl hydrazine and triazine. So all these classifications you all will be knowing. You might have studied in pharmacology in your third year. So let me give a introduction about all these drugs, how it exerts its cytotoxic activity. So in this session, we are not going deep into the pharmacokinetics and its mode of elimination and how about the scope for the dosage adjustment. So for discussing all these things, we need to get to know about the pharmacokinetics of each and every drug. So for that, there is a possibility we could conduct a separate module, but since this module deals with the basics of oncology, I'm just going to give a brief introduction about each and every drug, how it exerts its cytotoxic activity. So, under the cytotoxic anti-neoplastic, as we have already discussed, we have all the alkylating agents and we have all the anti-metabolites. So, anti-metabolites means we have folate antagonist, we have purine antagonist and pyrimidine antagonist, and also we have topoisomerase inhibitors and some of the anthracycline antibiotics also. Okay, so we can divide these drugs at the level of its action, whether it is acting specifically at certain cell cycle phase or else it is non-specific. The drugs like vinblastine, methotrexate, 6-mercaptopurine, all these drugs act at specific phases in the cell cycle. But other drugs like the alkylating agents, cyclophosphamide, chlorambucil, topotecan, all these drugs are non-specific. Okay, they may act on the actively dividing cell and also in the resting cell. Okay, but these drugs, vinblastine, methotrexate, vincristine, all these drugs will exert its activity only at the specific phase of the cell cycle, which we will discuss in the upcoming slide. Okay, so what are the mechanisms? So these chemotherapeutic agents may exert its activity by creating a direct damage to the DNA. Okay, so second one, it can inhibit the synthesis of new DNA strands. That is the DNA replication process which occurs during the S phase of the cell cycle. The third thing, it can stop the mitotic process which occurs during mitotic phase. Okay, these three, it can create a damage to the DNA, it can inhibit the synthesis of new DNA strands, or else it can stop the mitotic process of a cell. So first, let us discuss about the alkylating agent. So what this alkylating agent will do, this alkylating agent will donate an alkyl group to another molecule by forming a strong covalent bond. Okay. So this alkylating agent, after administration, it will form a highly reactive carbonium ion. Okay. So this carbonium ion will transfer the alkyl group by forming a strong covalent bond with the cellular constituents. So those cellular constituents can be a nucleophilic substances, or it can be some enzymes and RNA, or and also it causes interstrand cross-linking in DNA. Okay, so usually DNA is made up of nitrogenous pairs. We have adenine, guanine, thymine, cytosine. But when you administer alkylating agent, it will transfer an alkyl group to the cellular constituent. The two by creating a strong covalent bond. So as a result, what will happen? Such constituents will not be available for the normal metabolic reaction. So which will ultimately result in cytotoxicity. Okay, and also these alkylating agents are bifunctional because they contain two alkyl groups. So it can cause intra-strand and inter-strand cross-linking, which can result in abnormal base pairing and consequently scission of DNA strands. Okay, so how the cytotoxic effect is produced by the alkylating agent? Alkylating agent transfers a alkyl group like an hydroxyl group, carboxyl group, or sulfhydryl group. Okay, so these groups are being transferred to the cellular constituents by forming a strong covalent bond. So as a result, what will happen? The cellular constituents will not be available for the metabolic reactions. And also these causes the cross-linking in the DNA. All these ultimately results in cytotoxicity. And the main site where this alkylating agent act is N7 of the guanine. Okay, N7 of the guanine is, since it is highly nucleophilic, it is the main molecular target for alkylation. Okay, and alkylating agents are cell cycle non-specific. They will act on both the resting cells and the dividing cells. Okay, it is not that it will act only on the G1 phase or the S phase. No, it is cell cycle non-specific. It can produce a cytotoxic effect on both the actively dividing cell and the cells those who are at the resting phase. Okay, so next we are moving on to cyclophosphamide. Take one example. So under the alkylating agent, we have many drugs. Cyclophosphamide, ifosfamide, many drugs we have, procarbazine, dacarbazine, like that. So let us take cyclophosphamide. So cyclophosphamide is an inactive drug, which is a prodrug. So after getting metabolized by cytochrome P450 system of enzymes, it will be formed into an active metabolite. So there will be a two metabolite formation. One metabolite will be responsible for the cytotoxic effect. Another metabolite, which is called acrolein, this acrolein is having the potential to cause hemorrhagic cystitis. So as a result, what will happen? There will be a ulceration on the urinary bladder. So the patient may experience the blood in urine. So that we will, in order to prevent that, so whoever the patient receiving high doses of cyclophosphamide, we will be giving supportive treatment with mesna. So those things we will be discussing in the next session, okay, about that supportive cares. So there will be a formation of two metabolites after being metabolized by cytochrome P450. One metabolite is responsible for the cytotoxic effect, that is aldophosphamide. Another one is the acrolein, which will cause hemorrhagic cystitis. Okay, so second one is a platinum coordination complexes. So platinum coordination complex, they have a broad antineoplastic activity. They can be used in various types of cancers like ovarian cancer, head and neck cancer, lung cancer, bladder, colon, rectum. It can used in various types of cancers. So how it acts? Usually, cisplatin. If you look at the chemical structure of the cisplatin, it will have two chloride group on one side and the two amino group on the other side. So when cisplatin is in the bloodstream, so usually it will be in an inactive state because of high chloride in the blood. So once it enter into the cell, there will be a low cytoplasmic. Due to the low cytoplasmic chloride ion, cisplatin will become reactive. So how this cisplatin is entering into the cell? By the active copper transporter called CTR1. So after getting enter into the cell, the cisplatin will become active and it will be hydrolyzed intracellularly. Okay, so after getting hydrolyzed, it will form a highly reactive moiety which may cause cross-linking in DNA. One more thing we have to understand cisplatin is cisplatin is slowly excreted unchanged in urine. Okay, so I'm just giving you some insights about certain drugs. I will not be able to explain about these important features about all the drugs, which we can conduct one separate module for regarding the kinetics and all. But certain important things are there that I will share with you. Cisplatin will be slowly excreted unchanged in urine. Its half-life is about 72 hours. So whenever we are administering the drug cisplatin, there will be an intense hydration. So before administering cisplatin, we will be giving 2 point hydration. That is plain NS will be infused to the patient. After completing cisplatin also, there will post hydration. So in that we will give electrolyte replacement. Cisplatin will cause electrolyte imbalance and also it is highly nephrotoxic. Since its half-life is 72 hours, it is also slowly excreted unchanged in urine. In order to overcome this, we will advise the patient to take plenty of oral fluids for about more than 5 liters per day. Okay, because it is having the potential to cause the renal impairment. Another platinum compound we have carboplatin. So carboplatin is less protein binding. So since it is a less protein binding, there will be a its half life will be very low and there will be a rapid elimination in kidney. So that when dosing the carboplatin, we will be calculating the doses based on the creatinine clearance, which we will be discussing at the end. So coming to the next drug, which are anti-metabolites. So anti-metabolites means it deals with the folates and it deals with the purines and the pyrimidines. So what happens during S phase? So in S phase, you all know that the DNA is replicated. So when this DNA replication begins, when the enzyme topoisomerase unwinds the coiled DNA. So you know the DNA is a double-stranded helical structure. So when this double stranded is converted to single stranded, there is a possibility of supercoiling since it is a helical structure, right? So there is a possibility of supercoiling. This supercoiling will be overcome by the enzyme topoisomerase, which will unwind the coiled DNA. And another enzyme called DNA helicase will break the bond between the complementary nucleotide bases. So as a result, what will happen? This will expose the nitrogen bases, which are of two types. We have purine bases and pyrimidine bases. Purines are adenine and guanine. Pyrimidines are thymine and cytosine. Now, once the DNA strand is opened, that is the double-stranded DNA is opened into a single-stranded DNA with the help of an enzyme called DNA polymerase. Each nucleotide base is which will get bound to a new partner. Okay, so that is this process you might have studied in DNA replication. Okay, so how the DNA replication occurs, you should be knowing before getting to know about the mechanism of action of purine pyrimidine antagonist. Okay, so after the DNA replication, what will happen? Adenine will bind with thymine, guanine will bind with the cytosine in order to form a new strand of DNA, which is an exact copy of an original version. Okay, so this now the DNA replication is occurring. But what about the nucleotide? The metabolic requirements for these nucleotides and their bases can be met by both dietary intake and synthesis from the smaller precursor, which are known as de novo synthesis. Okay, so what is de novo synthesis? If I'm explain, I think it will be time consuming. If the time permits, I will explain at the end. Okay, so by de novo synthesis only after by series of reactions which are catalyzed by various enzymes, as a result, the nitrogenous bases will be incorporated into DNA. Okay, so cancer cells are actually highly dependent on the de novo synthesis of nucleotides to maintain the sufficient pools, to support the DNA replication and the products of the RNA. Okay, so as a result, the purine and pyrimidine synthesis after the de novo synthesis, through which only the nitrogenous bases will be incorporated into DNA. So these antimetabolic drugs like 6-fluorouracil or mercaptopurine, all these drugs acts by inhibiting certain enzymes which catalyzing the series of reactions in this purine and pyrimidine synthesis. By inhibiting these enzymes, they are providing a cytotoxic effect. So if you want to get deeper into that, if the time permits at the end, I will explain the de novo synthesis. Okay. Okay. Okay, I will explain. Right. So what happens usually in the de novo synthesis, there is something called phosphoribosyl pyrophosphate. This is PRPP. So this PRPP along with amino acid and folate, it will form a inosine monophosphate. Okay, IMP. So this monophosphate the enzyme synthesis will form the adenosuccinate. Adenylosuccinate will be with the help of an enzyme lyase, it will be converted to AMP. and AMP will be reduced to deoxy AMP, and deoxy AMP will be converted to deoxy ATP. This deoxy ATP will be incorporated into DNA. And on the other side, this inosine monophosphate with the help of an enzyme hydrogenase, okay, hydrogenase, it will form xanthine monophosphate. This xanthine monophosphate will be converted to GMP. GMP will be reduced to deoxy GMP. Deoxy GMP will be converted to deoxy GTP. Now this deoxy GTP will be converted to DNA. Now we have DATP and DGTP get incorporated into DNA. This is how the de novo synthesis by which the purine bases like adenosine and guanine are being synthesized and incorporated into DNA. This is a normal mechanism, and this reaction is being catalyzed by a series of enzymes. Okay, and about the pyrimidines. So pyrimidines we have orotate and same phosphoribosyl pyrophosphate. So these two form the uridine monophosphate. So uridine monophosphate will get phosphorylated to uridine triphosphate, and which will get aminated to cytidine triphosphate. Cytidine triphosphate will be reduced to deoxy CTP, and this deoxy CTP will get incorporated into DNA. On the other hand, this UMP will be converted to deoxy UMP. Deoxy UMP will be with the help of an enzyme thymidylate synthase, it will be getting converted to DTMP. Again, DTMP will be converted to DTTP. So as a result, the pyrimidine bases like cytosine and thymine get incorporated into DNA. This is a de novo synthesis by which the purine and pyrimidines are getting synthesized and getting incorporated into DNA. Now, coming to the mechanism. Now, let's take a drug mercaptopurine. Okay. So this mercaptopurine is a prodrug. So this prodrug will be converted to thioinosine monophosphate, which is TIMP. Okay, TIMP, which you can see here. Wait. So you can observe here TIMP. Okay, this is thioinosine monophosphate. It will the prodrug will be converted to TIMP. Now this TIMP will inhibit the several chemical reactions that involves inosine monophosphate, including the conversion of IMP to adenylosuccinate. So normally what we have seen, IMP will be converted to adenylosuccinate and also xanthine monophosphate. These two reactions are inhibited by this thioinosine monophosphate. So if these two reactions are inhibited, as a result, what will happen? There will no further reactions, and the corresponding the purine like adenine and guanine will not get incorporated into DNA. So as a result, there is a cytotoxic effect. So this is how the mercaptopurine exert its effect. So and also, furthermore, through the series of reactions, this TAMP can be converted to thioguanine triphosphate. This is TGTP. Okay, you can see here TGTP, which gets incorporated into RNA. So as a result, there is an inhibition of RNA synthesis, as well as there is a production of thiodeoxyguanine triphosphate. This is TDGTP, thiodeoxyguanine triphosphate, which will incorporated into DNA. So as a result, what happens? There is an inhibition of both DNA and RNA synthesis, which ultimately results in cell death. So this is how the mercaptopurine acts. So we have to understand the de novo synthesis process. So what are all the enzymes involved in this reaction? Then only we could get to know about the mechanisms. And also there is another drug called hydroxyurea. This hydroxyurea will inhibit the enzyme ribonucleotide reductase. So these enzyme will catalyze the conversion of AMP to deoxy AMP and GMP to deoxy GMP. So if this reaction is inhibited, there is no deoxy GTP and deoxy ATP. So these two purine bases cannot get incorporated into DNA, which ultimately results in cytotoxicity. Okay. Now coming to the pyrimidine antagonist. So one classic example we can take is 5-fluorouracil. So how the 5-fluorouracil acts its activity. So 5-fluorouracil, you can see, which is also a prodrug, which gets converted to 5-fluorodeoxyuridine monophosphate here. 5-fluorodeoxyuridine monophosphate and 5-fluoro uridine triphosphate. Okay, these T2. Now, this 5-fluorodeoxyuridine monophosphate is inhibiting the thymidylate synthase. Okay, we have already seen the normal mechanism. What is the role of the thymidine synthase that we have seen? So, here the thymidine synthase for the conversion of wait. So, it inhibits the thymidine synthase. As a result, what will happen? There will not be deoxy TMP. This 5-uracil 5-UTP, 5-UTP is recognized as an RNA substrate and it will get incorporated into RNA by RNA polymerase. So as a result, it will inhibit the RNA synthesis and function. Okay, so 5-fluorouracil is a well tolerated drug, but in order to find a equal efficacy, in order to find an oral form with equal efficacy, well tolerated, more bioavailable oral alternative is capecitabine. So both 5-fluorouracil and capecitabine are the same drug, but it is parenteral. It is available in oral form. Capecitabine is available in tablet. Okay, so capecitabine, if you give converted to active form, which is 5-fluorouracil. Okay, so now this thymidylate synthase, thymidine synthase, it will phosphorylate the thymidine phosphorylase enzyme. Here the capecitabine we are giving. Capecitabine is a prodrug which is oral form. It will be converted to its active form 5-fluorouracil. Okay, so this thymidylase enzyme, phosphorylase enzyme, is happens to be highly concentrated, primarily in the tumor tissue. Okay, so that's why it gives the capecitabine greater selectivity and toxicity than 5-fluorouracil because this enzyme is highly concentrated in the tumor tissues. Okay, so, these drugs, both the purine and pyrimidine antagonists, interferes with the normal de novo synthesis process by which the purine and pyrimidine are getting synthesized. So, as a result, there is no possibility for these nucleotide bases to get incorporated into DNA. So, as a result, there will be a cell death. So, next class of drugs are mitotic spindle poisons. So to produce the two daughter cells, if we want that to happen, so the microtubules must be assembled and stabilized in correct position. So the mitosis metaphase both four phases now. So in order for the successful mitosis, the microtubules must be assembled and stabilized in correct position. Each microtube is constructed from the alternating alpha and beta tubulin. You can see here. So there will be an alternative alpha and beta tubulin dimers. Okay. So these molecules will form a stiff, hollow, cylindrical structure. See, as the microtubules lengthen and shorten by addition and loss of tubulin subunits at their ends, they push and pull a chromosome apart to opposite ends of the cell. The chromosome has to travel from the one end to the another end. So during that process, they will push and pull the chromosomes at to the opposite end of the cell. Now, these mitotic inhibitors, spindle poisons, they act by interfering with the dynamics of this microtubule growth, which is referred to as the polymerization, and microtubule shortening will be referred as a depolymerization. So growth is polymerization. Its shortening is referred to as a depolymerization. So we have vinca alkaloids, which is vincristine, vinblastine, and vinorelbine. They destabilize the microtubule structure by binding to the beta subunit. Okay, they destabilize the mitochondrial structure by binding to the beta subunit. As a result, it will inhibit the polymerization of tubulin into microtubule. So microtubule is important for a mitosis to happen. So as a result, it will inhibit so that the cell will not undergo complete mitosis. So as a result, it will die. And also in contrast, we have taxanes. Taxanes promote stabilization of microtubule by binding to their own distinct sites on the beta subunit at the inner side of the microtubule lumen. So thereby it will inhibit the depolymerization and it will result in large, stable, dysfunctional microtubule. It will be abnormal. Okay, it will prevent the disassembly. It will enhance the polymerization, but there will be an abnormal bundles of microtubules. That is the difference between the vinca alkaloids and taxanes. Vinca alkaloid stabilizes, Okay, it inhibits the stabilization and it causes it inhibits the polymerization. But taxanes prevents the depolymerization and it stabilizes. But here the dimers are there, na, alpha beta subunits. They are abnormal. There are abnormal bundles of microtubules will be produced when we are giving taxanes like paclitaxel and docetaxel. Another class of drugs we have topoisomerase inhibitor. We have already told you. So when the double stranded DNA is getting converted to single stranded DNA, there will be a possibility of supercoiling. So this supercoiling will be inhibited by the enzyme topoisomerase. So if we inhibit this enzyme, what will happen? There will be a resealing of DNA strand will be prevented. So that there will be further DNA replication will be inhibited there. Okay. Say this drug is most active in late S phase and early G phases of the cell cycle. So we have etoposide, teniposide and all. So next we have topoisomerase 1 inhibitors, that is irinotecan and topotecan. Topotecan will be using most commonly in relapse to ovarian cancer and irinotecan will be used in the rectal cancers and all. Irinotecan along with capecitabine also they will use. So they also act by same mechanism. They will inhibit the topoisomerase enzymes, which prevents the supercoiling. And then we have certain drugs called anti-tumor antibiotics. Okay, anti-tumor antibiotics, which are commonly referred to as anthracyclines. So these anthracyclines will act by a mechanism called intercalation. So what is intercalation? It is a process by which the drug insert itself between the adjacent DNA pairs. So as a result, what will happen? There will be a significant disturbance of the DNA conformation and result in the inhibition of transcription and replication. In addition, this intracalated anthracycline, no, this will form a stable complex with the topoisomerase 2, which will result in DNA fragmentation, which ultimately prompts the cancer cell to undergo apoptosis. Okay, there are three mechanisms. One is the intercalation, another one is the DNA fragmentation also it can cause. So now dihydroxyurea we have already discussed. It acts on the de novo synthesis of purine and pyrimidine. Especially it inhibits the enzyme ribonucleoside diphosphate reductase. So which catalyzes the reduction of ribonucleotide to deoxyribonucleotide. Okay. So since it is inhibited, the further incorporation of the purine metabolites, purine nucleotides into the DNA is not possible. So next we have L-asparaginase. So this L-asparaginase is an enzyme. So usually we will be giving it in the form of pegylated L-asparaginase, which will be a small vial, 5 ml vial, which will contain 3,750 units. So what is this L-asparaginase? So at G1, no G1, what happens in G1 phase? So protein synthesis will happen. So one of the building block of many of the protein is asparagine. That is amino acid asparagine. Okay. So normal healthy cell can synthesize the asparagine with help of an enzyme, asparagine synthase. Okay. But some tumor cell, especially leukemic cells and all, they lack this enzyme and it will depend on the exogenous supply for their survival. Now we are giving L-asparaginase. Asparaginase is an enzyme that will break the asparagine into ammonia and aspartic acid. So as a result, what will happen? There will be a depletion in asparagine. So as a result, protein synthesis will not happen. So cell cycle will get arrested at G1 phase. So as a result, the cell will undergo apoptosis. Okay, why we are giving in pegylated form? Because L-asparaginase, if you give plain asparaginase, there is a possibility for a patient to develop allergic reaction. So if you are giving in pegylated form, it is less allergy. Okay. So till now we have discussed about the various chemotherapeutic cytotoxic agents. We have discussed how the alkylating agent exert its cytotoxic activity, how the antimetabolites, how the plant alkaloids like mitotic spindle poisons, vinca alkaloids and taxanes exert its cytotoxic activity, and some of the anthracyclines, hydroxyurea and L-asparaginase. Another one broad modality of treatment is a hormones. Okay, so hormones plays an important role in several cancers like breast cancer, is prostate cancers and all. Example, Let us take estrogen. Okay, so estrogen is an hormone that promotes carcinogenesis, especially in tissues of the female reproductive tract and breast. Okay, so estrogen plays a very important role in promoting carcinogenesis. So how all uh, we can inhibit the estrogen exposure, or we can reduce the estrogen in the body. So first thing, we can reduce the amount of estrogen in the body. So that is to interfere with its production by targeting the aromatase enzyme. So that's why we are giving aromatase inhibitors. Okay, so first approach, what we can do is we can reduce the amount of estrogen in the body. So for that, we can target an enzyme aromatase. So for that, we are giving aromatase inhibitor. Second one is selective estrogen receptor modulators, SCRMs. One classic example is tamoxifen. Okay, so which will usually be given for the patients who's with ER positive breast cancer. So we will be conducting the molecular study. They will check whether the ER positive, PR positive, estrogen receptor, progesterone receptor, and HER2. If all the three are positive, it is called triple positive breast cancer. If all the three are negative, it is called triple negative breast cancer. So the thing is, we have to uh, four ways by which in which the estrogen process is important in development of certain cancer. So such as the breast cancer, we can interrupt by four ways. So one is reducing the amount of estrogen in the body. How we can do that? To interfere with its production by targeting the enzyme aromatase. Second one, we can modulate the selective estrogen receptors. Third one, we can downregulate the estrogen receptor. That is, we can reduce the expression of estrogenic receptor. One classic example is fulvestrant. So fourth one, we can suppress the ovaries. So for that, what we can do? So usually, how the ovary will be secreting the follicular stimulating hormone and luteal hormone in response to which will be reduced by the pituitary gland in response to the signal from the hypothalamus. So this FSH and luteal hormone will secrete the estrogen. Okay, so those things we can make certain changes like SCR modulators. We can reduce the expression of estrogenic receptors, and we can reduce the amount of estrogen by inhibiting the enzyme aromatase. And other hormonal drugs, we have glucocorticoids like prednisolone, and we have 5 alpha reductase inhibitors like finasteride, and gonadotropin analogs like nafarelin, which we will discuss in the upcoming slides. So first, we have glucocorticoids. So all the hormonal receptors are intracellular. So, once the substrate gets binds with the receptor, that receptor substrate complex will be translocated into the nucleus. So there it will induce some reaction. So in the cytoplasm, after binding, it may cause some conformational change will occur, which may induce the dimerization, whatever. Okay. So after the substrate, that is the particular hormone is getting bind to the receptor, it will be translocated to nucleus. It will bind to specific regions on chromatin, and further it will activate the transcription of specific gene so that the cell growth and proliferation will be increased. Okay, this is a normal thing. But glucocorticoid, after binding, it will be translocated to the nucleus, and it induces anti-proliferative and apoptic response in sensitive cells. So usually in lymphoma and leukemia, they will be, since it inhibits the proliferation of lymphocytes, so it is used as a cytotoxic here. So because of its lympholytic effects, so usually prednisolone they will be giving for leukemia cases. Second one is estrogen. I have already told you. We can reduce the estrogen amount by targeting aromatase. We can downregulate the receptor, or we can modulate the receptor. Okay, and then we can deal with the gonadotropin releasing hormones. So selective estrogen receptor modulators, classic example is tamoxifen. So it is competitive inhibitor of estradiol bind to the estrogen receptor. Okay, most commonly it is prescribed for breast cancer if the molecular report is ER positive. Okay, second is the third is a selective estrogen receptor down regulators. Example fulvestrant. Okay, it is an anti-estrogen that binds to the ER with an affinity more than 100 times that of the tamoxifen. So then we have aromatase inhibitor. So aromatase is an enzyme which is responsible for the conversion of androgens and androstenedione into testosterone to estrogen. That is E1 and E2. Estrone and estradiol are biologically active estrogens. So if we inhibit the conversion of androgen to estrogen, so the amount of estrogen in the body will be reduced. So next we have anti-androgens. They bind to androgen receptor, and competitively it will inhibit the binding of testosterone and dihydrotestosterone. So currently the anti-androgen monotherapy is not indicated as first-line treatment for patients with advanced prostate cancer. So hormonal therapy most commonly applicable for the prostate cancer in male, breast cancer in female. Most commonly I'm telling you. So for prostate we'll be giving anti-androgens, 5-alpha reductase inhibitors, those things. And for breast cancer, if it is ER positive, we'll be giving this tamoxifen or fulvestrant like that. So 5-alpha reductase is an enzyme that catalyzes the conversion of testosterone to dihydrotestosterone. So classic examples, finasteride, dutasteride, which usually prescribed for the patients with prostate cancer. Okay, next gonadotropin releasing hormone analogs. It will indirectly inhibit the estrogen and androgen secretion by suppressing the follicular stimulating hormone and luteal hormone release from the pituitary gland. So with that, we have completed the hormonal. So first is a chemotherapy, cytotoxics, and that we have uh, cytotoxic antineoplastic, targeted antineoplastic. So under that, we have discussed about the various cytotoxic drugs, how it exerted cytotoxic activity, and then we have discussed about various hormonal drugs. Now coming to the immunotherapy and targeted therapy. So what is immunotherapy? So immunotherapy is a growing concern actually. So we are getting more advanced. Still, many research are going on regarding the immunotherapy. But these immunotherapy are quite expensive. All the patients cannot afford. So usually they will be monoclonal antibodies, which will be costing around ranges from 50,000 to 2 lakhs and all. It is available. So how this immunotherapy acts? Immunotherapy uses our immune system to fight cancer. You all know normally, if anything is abnormal in our body, the immune system will activate and it will start acting against it. But even though the cancer cells are being abnormal by various mechanisms, it will be escaping from the immune cells. Okay, so what this immunotherapy will do, it will help the immune cell to identify the abnormal cancer cell by using some monoclonal antibodies. Okay, so that is what happening in immunotherapy. So immunotherapy uses our immune system to fight the cancer, and the reason more commonly these immunotherapy are useful in renal cancer, lung cancers, and skin cancers, the melanoma, renal cell carcinoma, and lung cancers. So for the lung cancer, we'll be using a drug called nivolumab. For renal, we'll be using called pembrolizumab, and skin cancers also we'll be using some drugs. And one more mode of immunotherapy is prevention. There is a vaccines. Okay, especially for the patients with the bladder cancer, after performing surgery, they will do a administration of BCG vaccine intravesically, directly into the urinary bladder via the urinary catheter. Okay, so what will happen by after the surgery by urinary catheter, there will be administration of BCG to the bladder. It will kill the cancer cell remain in bladder after surgery. If there is any residual present, it will kill the those cancer cells. So mainly immunotherapy helps the immune system to fight the abnormal, to fight and kill the abnormal cancer cells. That is what happening in immunotherapy. It will boost the effectiveness of the patient immune system, and it will help the immune system to detect and fight against those cancer cells. So if for that we can use monoclonal antibodies, and we can use some checkpoint inhibitors, and there are some cytokines and vaccines. Vaccines I told you, BCG after surgery in bladder cancer. So monoclonal antibody works as an immunotherapy in different ways. So what they can do, they can trigger the immune system to attack and kill the cancer cells. So they can trigger the immune system, or else it can act on the cells to help the immune system to attack. So usually you all know that all the cells having certain proteins or certain receptors. These monoclonal antibodies will go and bind onto the receptor. So with it, which will be easy for the immune cell to identify. Okay, so to identify that it is an abnormal cell. This is nothing but the antibody dependent cell mediated cytotoxicity is there. So the same mechanism is here. Okay, the monoclonal antibody will trigger the immune system to attack and kill the cancer cells. Okay, they will attach themselves to the cancer cell, and which will make it easier for the immune cell to identify and attack the cancer cell. This is the first thing. So examples, we have rituximab. So rituximab most probably will be using for some types of non-Hodgkin's lymphoma. So am I audible?
Yes, sir.
Okay. So we have rituximab, which we will be using for non-Hodgkin's lymphoma, CD20 inhibitor. So what will happen? It will be targeted against the CD20. So what is the main advantage in targeted therapy? They will be selective to the tumor cell. Okay, so comparing to chemotherapy, chemotherapy are not selective to the cancer cell. They will attack both the cancer cell and the normal cell. So that's why there are unacceptable toxicity. But in case of targeted therapy, these agents are targeted against the particular tumor cells. So there is a less toxicity when comparing to that of the chemotherapy. So we have rituximab, and also there is a drug called cetuximab. We'll be using for the bowel cancers and head and neck cancers. We have used cetuximab, and there is a drug called trastuzumab, especially useful for patients in breast cancer. Okay, so but the disadvantage is these drugs are quite expensive. So all the patients cannot afford, but the efficacy is very good, and the acceptance, patients tolerability also very good. So what are monoclonal antibodies? They are immunoglobulins. Okay, they are produced by the hybridoma cells in culture. Okay, we have various types of monoclonal antibody, which are murine, chimeric, humanized, fully human. So monoclonal antibody comprises of murine, means, but that is from the mouse. Okay, so 0% completely, if it is made from the mouse, it is called murine. So the monoclonal antibody which are murine will be ending with OMAP. Okay, that suffix will be OMAP. If you look at the drug, it will end with OMAP. And chimeric monoclonal antibody, 65% will be humanized. So you know the immunoglobulin, we have constant region and variable region. Only in the variable region only the some changes will be made. Okay. So Zimab suffix, for example, cetuximab, rituximab, those drugs are chimeric monoclonal antibody. And if it ends with Zumab, okay, trastuzumab, pertuzumab, pembrolizumab. So all these drugs are humanized monoclonal antibody. That more than 90% will be humanized. So completely human will be 100% human. Okay, we have one classic example, nivolumab, which we are using in lung cancer, which is an immunotherapeutic agent useful in the treatment of lung cancer. Okay. So we have already discussed rituximab is a monoclonal antibody. It is a CD20 inhibitor. So it can be used in the treatment of lymphoma. So, and then we have trastuzumab used in the treatment of breast cancer, which will be targeted against the HER2. Okay. So after taking out the tumor, department cancer oncology and cancer biology. Okay, molecular diagnostics and cancer biology. So we will be sending the sample, tell you the molecular report. So whether the presence of any receptors, any particular proteins, any particular targets for in order to apply the targeted therapy. If there is an option, we may go for targeted therapy, and if the patient is affordable. And we have bevacizumab, so used in the treatment of colorectal cancer, which is targeted against vascular endothelial growth factor. Cetuximab will be targeted against EGF receptors. Okay, so these targeted drugs will be targeted against certain proteins or the receptor present on the surface of the cell. Okay, there will be a target to specific cancer cell receptors or proteins. So it will be targeted against that target, which will bind to that. So that will be selective that is selective killing activity, so that the normal cells will not get affected. So with that, I have done with the basic foundations about how the various anti-cancer drugs exert its activity. So now stepping into the dosage calculations. So usually we will be calculating the dose based on the weight and the body surface area. Okay, so all the anti-cancer drugs, as per the manufacturer's information, as per the research, so they will be giving per meter square dose. For example, if you take rituximab, it is acceptable to give 375 mg per meter square. So with that, we have to calculate. We have to get the patient's height and weight. So with that, we have to calculate the body surface area, and from that, we have to calculate if it per meter square, if it is 375. So for the patient body surface area, how much dose is to be given? That we have to calculate, and if any dose adjustment to be made, that adjustment has to be made, and the final whatever the value comes, so we can have the plus or minus 10% variance. Okay, so it is not acceptable to give the fractional dose. If it is the fractional, it is all acceptable to make it to a nearest integer. If it is 53, it is always acceptable to make it 55 or 50. Okay, so fixed dose prescribing usually followed for the monoclonal antibodies and some of the uh, orally chemotherapeutic agents like tyrosine kinase inhibitors and checkpoint inhibitors, which is an immunotherapeutic agent. And as I already told you, carboplatin, so which is higher, which is low protein bound, which half life is considerably low. High amount of drug will be available for the rapid elimination. So for that drug, we will calculate the dose based on the creatinine clearance. Okay, so that I will explain in the upcoming slides. So how to calculate the body surface area? We have various formulas, but the one which we are clinically using is the Mostellar formula. So which is height in centimeter into weight in kg divided by 3600 square root. Okay. So this is what we are using clinically, the Mostellar formula. The another one formula is also there, Du Bois formula. So body surface area up to 2 meters square is acceptable. So if suppose if the patient is overweight, if the patient is obese, we will be taking the adjusted body weight. So if suppose if the body surface area is more than 2, we cannot calculate the dose for 2.1 meter square, 2.2 meters square. So in that cases, we have to go for adjusted body weight. So adjusted body weight can be calculated by ideal body weight plus 0.4 into weight minus ideal body weight. So ideal body weight also there is a formula. So there's a constant which is 50 for men and 45.5 for women. So all these formulas we have studied in biopharmaceutics and pharmacokinetics. So that is in our fourth year syllabus. Okay. So we have to, if the body surface area is unacceptable, we will know the patient is obese or if it is overweight, body surface area more than 2, we have to calculate the ideal body weight, from which we have to calculate the adjusted body weight. And with the adjusted body weight, we have to calculate the dose required for the patient. So coming to the carboplatin dosing. For the carboplatin dosing, we will be using a special formula called Calvert's formula. So Calvert's formula is nothing but area under the curve into GFR plus 25. Okay, so what is the area under the curve? Area under the curve is a target plasma concentration. For example, if the patient is coming for a chemo. So today we will be checking the creatinine clearance. How we will get the creatinine clearance? We could only get the serum creatinine. From the serum creatinine, we have to calculate the creatinine clearance by Cockcroft-Gault equation. So after getting the creatinine clearance, we have to calculate the carboplatin dose. This area under the curve, usually it ranges from 1 to 6. So suppose if it is a 3 weekly cycle, patient is taking carboplatin 3 weekly once, they will keep the AUC as 5 or 6. Usually they will give 5, they will not go for 6. Suppose if it is a weekly protocol, weekly the patient is taking carboplatin, AUC will be kept as a 2. Okay, so because if you keep increasing the AUC, there will be an increased plasma concentration. So as a result, what will happen? Increase the chances of nephrotoxicity because this drug is rapidly eliminating in urine. Okay, so that for weekly protocol, AUC will be kept as a 2. For 3 weekly, it is advisable to keep it as 5 or sometimes it is 6. At maximum dose carboplatin, they will cut off with the 600 mg. Okay, so into creatinine clearance plus 25. So for the carboplatin only, the dose will be calculated based on the creatinine clearance. For all other drugs, it be depending on the patient tolerability, depending on any complaints, the dosage adjustments will be made. So when all the dosage adjustment is acceptable, because these cancer cells are narrow therapeutic. So we call, if the dose is higher, it will be high toxicity. If the dose is lower, there will be a subtherapeutic dose, no anti-tumor activity. The disease will keep on progressing. So if the patient is having neutropenia, so neutropenia usually for hemat cancer, WBC less than 2000 or 1500, they have to go for the supportive therapy. That is, they will be giving stimulating factor GCSF, like that. So for the solid tumors, it is acceptable if it is 3,500 or even 3,000. If the patient is tolerable, they will be proceed with the chemo. And patient unable to tolerate the previous dose. For example, patient completely malnourished, completely fat, tired, and severe vomiting. Patient is hospitalized. So in that cases, based on the tolerability in the previous cycle, they will adjust the dose in the subsequent cycle. There is no specific guideline for dosage adjustment. It is like a trial and error. So out of the calculated dose, they will give the 80 percentage of the calculated dose or else 75 percentage. Like that, they will try. If the patient tolerates well, next subsequent cycle, they will increase based on certain parameters. And also, there is an unexplained weight loss in some patients, more than 10%. Suppose the patient is 70 kg. For the next cycle, if the patient lost almost 6 to 7 kg, in that case, we have to consider for dose adjustment. And I have told you there is a neoadjuvant chemotherapy and adjuvant chemotherapy. So for example, there is a protocol called FLOT, which consists of 8 cycles, which consists of 4 drugs. FLOT means 5-fluorouracil, oxaliplatin, docetaxel. With that, they will give calcium spodumene. Okay, these 4 drugs comprises the protocol FLOT, which is consist of 8 cycles, particularly useful for stomach cancer. So in that 4 cycles, given as a neoadjuvant. Then the patient will meet the surgeon. If the patient is fit for the surgery, they will surgically remove the tumor. Post surgery, that is a post surgery, the first cycle will be at the 75 percentage dose because after the surgery, the patient will be weak, immunologically weak. The patient will not be able to tolerate. So usually at that time they used to adjust the dose for the first cycle. Subsequent cycle they will give the normal dose. Okay. So and then the other dose adjustment scenario is in the presence of renal impairment or hepatic impairment. Okay, and hepatic impairment also they will check for the SGOT and SGPT. If it is 3 times higher than the upper limit, so what's the upper limit? It is 40 to 45 units. Suppose if the SGOT and SGPT is more than 100, 120, at that time they will not give that particular drug. They will not give the chemo. So they will check for the reason. What is the if any comorbidity, if any hepatitis happened. So accordingly, they will choose another alternative drug. Okay. Suppose if the patient previous cycle the SGOT, SGPT were found to be normal, but this cycle it is found to be abnormal. They have to correct the liver. They have to correct hepatic correction by giving some liver protective by supportive care. They have to correct the abnormality and then they have to proceed with the chemo. Okay, so that is the one thing about the renal impairment. So, for anti-cancer drugs that are eliminated via the kidney, so diminished renal function might decrease their metabolite excretion. So, especially the platinum compound, this platin or carboplatin are highly nephrotoxic. They are rapidly undergo predominant elimination in kidney. So, those whose doses needs to be adjusted. So, if the creatinine clearance is less than 40 or 50. Okay, so at that time, they will not go for these nephrotoxic drugs. Okay, they will go for some other alternative. Suppose if it is 60, 75 like that and all, proportionate percentage they will reduce. For example, 60 percentage of the dose, 70 percentage of the calculated dose. Only they can adjust with the proportionate of the calculated dose. Okay, specific guideline that it's not any approved guideline for dosage adjustment for renal and hepatic dysfunction. It's almost like a trial and error, depending on the patient tolerability only. And for monoclonal antibody for the immunotherapeutic agents, no need of dose adjustment in case of hepatic and renal dysfunction because their elimination is by the proteolytic catabolism and intracellular degradation. So that is nothing to do with the hepatic dysfunction and renal impairment. Okay, so those doses need not to be adjusted. But whereas other drugs, if it is eliminated by kidney, so what they will do, they will go for other alternative which are renally safe. Suppose if there is an hepatic abnormality, SGOT, SGPT is abnormal, we have to look for a reason. If the patient is having any hepatic comorbidity like hepatitis B, so accordingly we have to choose that drug. Suppose previous cycle the patient LFT parameters were found to be normal, but this cycle it is abnormal. Means we have to correct it. Then we have to proceed with the chemo. So So if any doubt, you can ask me. Am I
Thank you
audible?
so much for the wonderful session. Participants are requested to unmute their mic or use chat box to drop questions.
So, if we for better understanding, we have to get deeper into the pharmacokinetics. Okay, so for getting deeper into pharmacokinetics, we need a separate session regarding the dose calculations, regarding the dose adjustment. Certain drugs, as I told, na, they will go for some other alternatives. So, to get to know about all these things, if there is a possibility, they will conduct a special another module regarding the dosages and kinetics of the antineoplastics. But in this module, we have completed the foundations and the basics regarding the mode of action of cytotoxics and about its dose calculation and about its adjustments. So, in that, if you have any doubt, you can put forward.
Participants, if you have any doubt, please post your questions in the chat box.
Hello, sir. Uh, Hariharan is asking about factors affecting dosage regimen in rare cancer like glioma.
Uh, those factors same within of the normal cancer treatments like patients' neutrophils count, their tolerability, what we have studied about dosage adjustment, either we can reduce the dose or we can we can reduce the dose or we can increase the frequency. So suppose if the patient not able to tolerate, suppose if there is a renal impairment at the time, if the dose is to be given at higher 3 weekly cycle, they will make it to low doses weekly cycle, that is they will reduce the frequency. Okay, 3 weekly high doses will be converted to weekly low doses. So that kind of strategy also the oncologist will follow.
So Prachi is asking about how is the choice of therapy determined for specific types of cancer.
Choice of therapy depending on the standard guidelines. The standard guideline will be the, especially for pediatric, there are many international guidelines are available. So which will tell about the combination of drugs. So the main thing is we are combining various classes of drugs to attain the that is cytotoxic activity. So choice of therapy, I don't know whether you are asking about immuno or if that level you are asking, it's depending on the acceptability. If there is an option for the targeted therapy, if there is an option for immunotherapy, they will go for that. And also, as I said, it is more expensive. If the patient is affordable, they may go for that immunotherapy and targeted therapy. Otherwise, they may go for conventional chemotherapy. But there, if you're asking how they are fixing, how they are deciding what drug to use, there is a guideline. There is various protocols. For example, if you take breast cancer, there is a combination with the adriamycin and cyclophosphamide. There is a combination called paclitaxel with the carboplatin. So like that, there are some traditional protocol with respect to the international guidelines that they will be followed. And if there is no acceptance, if the patient is unable to tolerate, the drug needs to be changed. At that case, they will choose some other drug with same mechanism of action, which are considered to be renally safe or hepatically safe. Like that, they will go for the alterations.
Sir Tharani is asking about how ADR is monitored and how are the drugs stopped or changed.
ADR monitoring by the laboratory investigation. Usually, if you're giving the chemo to the patient, there will be a considerably decrease in the total count, that is WBC and all. So both patient will be more susceptible to various infections. In that cases, we have to ensure the prophylaxis is being given. And other ADRs like mucositis will happen to the patient. So ADR, we are having another session. So in that we will be discussing regarding the drug stoppage or changed. So regarding the ADR, we will not stop the drug or change. So of course, all the drugs are about to cause the ADRs, right? So here about the patient acceptance, if the patient is not able to tolerate, or definitely the drug needs to be changed because of other comorbidity, because any other renal impairment, renal insufficiency. In that case only they will go for another alternative. There is no need of stoppage of drug because of ADR. For managing ADR, we will be giving supportive care. For example, all the chemotherapeutic agents are about to cause the nausea and vomiting. So for that, we will be giving anti-emetic prophylaxis also, and post chemo also, we will be giving the anti-emetic drugs.
Thank you, sir, for your wonderful session. So, all the participants, there is a special announcement that tomorrow's session is postponed and it will be compensated on day after tomorrow. And that session will be of 1 hour and 30 minutes. So, thank you for your joining this session. So, Vaishnavi is asking about what reference can be used for studying pharmacokinetics and dynamics of anti-cancer drugs. Can you suggest if there is any mobile application or free online book, PDF to refer this?
Yeah, there are many books available, international publications. All those books were written by the PharmD graduates. So we are only less updated, less knowledgeable about that. So more international therapeutic related books are written by the PharmD graduates only. So for understanding about pharmacokinetics, you may go for our normal Tripathi and all. So for the KD Tripathi.
Other questions will be answered in the next session. So thank you so much, everyone, for joining for today's session. Thank you.